finish, let's do some hepatitis. You've had microbiology, which includes virology. So you're all experts on hepatitis A, B, C, and D, and E, aren't you? No? Well, let's have a little short quiz. Are you ready? Most common hepatitis. Hey, guys, listen. A, B, C, D, E. That's it right there. A most common, B next most common, C next most common, D next most common, E next most common. I just love it when it works out like that. Okay, two of them that aren't necessarily transmitted parentally. A and E. Okay, good. Which ones never produces a chronic carrier state? A. What about E? Only if you have E and you're pregnant. And then you could have, you can get the chronic liver disease. Which one requires another infection before you can infect? D, right? Very good. Good. How about the one that you would get in daycare centers? A, very good. That's a big one. There's an epidemic of hepatitis A in daycare centers. Any child that goes to a daycare center should have a hepatitis A vaccination. That's a recommendation of pediatricians. How about ones in states, jails? A. Okay, A again. IV drug abusers? B. Okay. Post-transfusion hepatitis? Okay. Most common infection by accidental needle stick? B. Good. You're not bad. You guys are pretty good, actually. You guys are good. From comparing you to a lot of other groups that I've had, you guys have been answering questions pretty good. I'd have to give you guys a pretty good grade. And I never flatter. When I say something, it's the truth. I don't like to flatter people. Now, one thing that I notice that people have problems with is hepatitis B, as in boy serology. A is simple, anti-HAV IgM, you got hepatitis A. Anti-HAV IgG, you had it, you're not going to get it again because it's protective. By the way, are the antibodies, anti-HCV IgG antibodies, protective? No, it means you have the disease. There are no known protective antibodies. So when you get a positive anti-HCV IgG, that doesn't mean you had it and you're recovered. It means you have the disease right now. And the same thing applies to hepatitis D. There's no known protective antibodies. So if you're anti-HDV IgG positive, you have active hepatitis D. The only protective antibodies are those for HAV, HBV, that's surface antibody, and hepatitis E. Those are the only ones that are protective. Okay, so the very first antigen that comes up in hepatitis B, first marker is surface antigen. Okay, so surface antigen usually comes up a month or so after you have the infection. You don't even know you have it. You're basically asymptomatic. Basically, all your enzyme studies are normal. Now, notice the very next thing that comes up are the bad guys. That's E antigen and HBV DNA, because both of those are infective. Those are the only infective particles, E antigen and HBV DNA. The only ones. And so they come up next. Then the first antibody comes up a little bit after E antigen and HBV DNA, and that's the dots here. That's core antibody IgM, as you would expect, because remember, the first immunoglobulin of acute inflammation is IgM. So it's core IgM. Now, the majority of people with hepatitis B recover, roughly about 90%. Okay, those that are HIV positive never do. They all go chronic because they have no immune response to knock it off. If you are to recover, then the very first thing to go away is E antigen and HBV DNA. They go away quicker. The last of the antigens that goes away is surface antigen. So the way I remember it is surface antigen is the first one to come and the last one to leave. It's kind of a house within a house. Okay, we have surface antigen here is a big house. Okay, and then within the house, okay, is E antigen and HBV DNA. So in other words, it is absolutely impossible to be E antigen positive and surface antigen negative. Impossibile. That means impossible. 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 Cannot be. Okay, you have to have surface antigen if you're E antigen positive, because E antigen and HBV DNA come up after surface antigen and leave before. Now notice, they make this big thing about a serologic gap. Serologic gap. Oh, there's a serologic gap in here. Whoa, before the surface antibody comes up. That's true of any infection. You don't think that whenever an antigen disappears within 1 second, the antibody comes up. There's always a 6 to 8 week interval there. I mean, I don't get this big idea about this gap thing, you know. There's a gap in every infectious disease. Okay, but whatever. Notice that the surface antibody doesn't come up until maybe a month or so later after surface antigen's gone, and so there's this little gap in here, a window in here, that's kind of only has one antibody that's there, isn't it? Surface antigen's gone, the E antigen's gone, HBV DNA's gone, surface antibody hasn't come yet, so how do you know the patient had hepatitis B? There you go. Core antibody IgM doesn't leave. It stays in there. Core antibody IgM stays in and eventually becomes core IgG over time. So the marker for that window, when all the bad guys are gone and surface antibody hasn't arrived yet, the marker that tells you you had hepatitis B and are in the process of recovery is core antibody IgM. There is no way you're infective during this period. That is obvious. Why? E antigen and HBV DNA are not there. Therefore, you are not infective. It just means that you had hepatitis B and you are in the process of recovery. I can't tell you that enough times. Yes, I can. You're not infective, you're not infective, you're not infective, you're not infective. If E antigen and HBV DNA are not there, you are not infective. Are they there between the 4th and 5th month? No. Therefore, you're not infective. They're gone. Okay. So if you had hepatitis B, then there should be 2 antibodies that you have. You should have core antibody IgG, and you should have surface antibody. How many have been vaccinated? What do you have? You have surface antibody. You can't have anything else. Why? Because you had yeast make surface antigen. And that's what you were injected with. And the only antibody you can get injecting surface antigen is antibodies against it. So the only thing that you're going to have is surface antibody. That's it. You're not going to have core antibody IgG. You weren't injected with that. You weren't vaccinated. Why would you want it? It's not a protective antibody anyway. Okay? Chronic hepatitis. That's a definition. Chronic hepatitis is purely how long have you had surface antigen. If it's more than 6 months, you have chronic hepatitis B. Period. That's it. No argument. Next step is going to be, are you infective or not? Are you, quote, a healthy carrier or an infective carrier? That's a no-brainer. You automatically know if you're an infective chronic carrier if you're what positive? The antigen, HBV DNA. That means you are a patient with chronic hepatitis B who's infective. That means that you're a disaster on wheels. That means that your intimate contacts all have to be immunized because you could potentially transmit the disease sexually to those people or by IV if you're IV drug abuser. Understand? If you're negative for E antigen and HBV DNA, but you're surface antigen positive, then that makes you a, quote, healthy carrier. Now, what does that mean? You're healthy? Oh, no. You still have chronic hepatitis B. Okay, but your chances for recovery are excellent because maybe in a year and a half or so, eventually surface antigen will disappear and surface antibody will come up and you're okay. And you'll have core antibody IgG also at that time. So it means you've got a real good chance of total recovery. You got a good chance, too, if you're E antigen, if you're an infective carrier, too, because you'll be a candidate for alpha interferon therapy, which, of course, is a board question. Okay, never give corticosteroids to patients with chronic viral hepatitis. But you get alpha interferon therapy, you got a pretty good chance of converting over and eventually everything going away. You don't necessarily have to go on into post-necrotic cirrhosis and run the risk of hepatocellular carcinoma. Okay, so let's see, wait a minute now, where is that slide? Where did that slide disappear? Let me go back here. Okay, must have not put it here, so I'll do it by myself. Okay, what would we expect then in acute hepatitis B? What would be the markers of acute hepatitis B? Well, we should have surface antigen, E antigen, HBV DNA, and core antibody IgM, right? That's all we should have. All right, good. What if we are in the window period? What should we have? Should have core antibody IgM. Very good. What if we had hepatitis B and we've long since recovered from it? What are you going to have? Core antibody, IgG, and surface antibody. Very good. What if you just were immunized, vaccinated? What's the only thing you should have? Surface antibody. Okay, now we get a little tricky. What if you have, at the end of 6 months, surface antigen, core antibody IgM, but everything else is negative? You're a healthy carrier. What if you have, after 6 months, surface antigen, E antigen, HPV DNA, and core antibody IgM? What are you? An infective carrier. Very good. You got it. That's good for 1, 2, and 3, guys. And we're talking about boards. You got it. Let's talk about other infectious diseases. Amoebiasis. Amoebiasis is always asked on boards. Entamoeba histolytica. Okay. Remember that the organism is resistant to acid, and so you swallow it, and it can resist acid, and then it exists in the cecum where there's an alkaline environment. And because it has the word histolytica at the end of it, it's got this chemical that can drill a hole through your mucosa, and you get these flask-shaped ulcers. Okay? Of course, you're going to have bloody diarrhea related to this. Okay? And unfortunately, because the cecum is drained by the portal vein, and you are forming an ulcer underneath there, there's a chance that the organism can get into a portal vein tributary and be distributed to the right lobe of your liver, where it will produce a abscess. And it'll start dissolving your liver, hence the term anchovy paste abscess, because it looks like anchovy paste because it's just brownish liquid. Okay, of course, if it wants to and be really mean, it can actually drill a hole through your right diaphragm and go up into your lungs and produce an effusion arrow, get into your systemic circulation and go anywhere it wants, brain, whatever. Treatment, metronidazole. Now look, please. These are the trophozoites of Entamoeba histolytica, and I think you can see red particles in them. Those are red blood cells. The only protozoa that can phagocytose red blood cells is Entamoeba histolytica. No other amoeba can phagocytose red blood cells. So it's a very, very characteristic finding. And every one of these trophozoites, this dude has about 3 of them in there. He's really having a good time. That's it. That's Entamoeba histolytica. Isn't it interesting? Metronidazole has been used in a lot of things. We were talking about giardiasis, treatment of Clostridium difficile infections, and now we got amoebiasis. We've got a lot of other ones. Wait till we get to GYN, bacterial vaginosis, trichinosis, okay, metronidazole. Okay, this is hydatid disease, echinococosis, always asked because you get screwed up between definitive and intermediate host. So let's make sure you understand what definitive means and intermediate when you're talking about hosts with this disease. Definitive means you have the sexually active worms that have the ability to mate and lay eggs. So you've definitively arrived. You are sexually active and you can mate and lay eggs. That's always the definitive host. Okay, the intermediate host is the dude that doesn't have the sexually active adults. They only have the larval form. So they're called intermediate hosts. Now here's the way it works, guys. Adult, egg, larva. So you go through those stages. Adult, lay eggs, eggs develop into larva. Okay? You can't jump stages. Okay, you can't jump stages. If you have the larva form in you, okay, what will that do? Stay there. Okay, can't go beyond that. If you have the egg in you, it can become the larva. But a larva can't go anywhere else. It's an end stage for it. Okay, so here we go on this disease. This is called sheepherder's disease. And it's due to Echinococcus multilocularis or unilocularius, however you say that. And it's a sheep herder or herderess. Let's not forget the fact that it could be a herderess. Okay, that's a female sheep herder. Sheep herder. Okay. Got to make some fun here. Got to make some fun. And there's always got to be a sheepdog. All right. So little Fido sees a little dead sheep there and starts taking a little bit of dinner. Okay. Now what's in the sheep? Well, in the sheep is larval form in the meat. So what's the sheep? Intermediate host. The doggy eats the sheep and has larva. Larva in it. What develops actually in the dog? Larva actually goes into the adult. Okay, and so the dog becomes the definitive host. The larval form can go into the adult and the dog, but not into the human. Okay, so the larval form from the meat of the sheep forms an adult in the dog. So the dog is the definitive host because it's got the sexually active worms in there. Of course, they lay eggs. Okay, dogs love to be petted, as you know. Okay, not everyone washes their hands before they eat. So the sheep herder or herderess could be petting their dog, not knowing that possibly they could get some eggs on their hand, which gets in their salad, and then they eat that, and so now they have the eggs in the mouth. So the sheep herder now has the egg. What's that going to form? The larva, and it stays there, and it can't go any further. So what's the sheep herder? The intermediate host. Okay. Got it? So the sheep's an intermediate host, the dog's a definitive host, the sheep herder is the intermediate host. Okay? All right. Remember that you don't want to rupture any of these cysts because if the fluid gets into the abdominal cavity, you go into anaphylactic shock. Okay? Those are the key things. Now, see, if you really understood what I said, let's deal with another one that deals with definitive intermediate hosts. You ready? Okay, that's the T-solium. Let's see if you really got that one down. T-solium. So, pig tapeworm, huh? So let's say you went to a barbecue, and they were going to barbecue pork, but they didn't cook it too good. So what's in the pig meat? The larva. Okay, so you eat that, okay, and what's the larva going to develop into in you? The adult. Okay, so you have the sexually active worms in you. Okay, so what are you? The definitive host, or what was a pig? Intermediate host. All right. Now you live in a family, okay, and you got one person in your family that is the definitive host. Okay, it's got these sexually active worms. It's got the eggs and that stuff in its stool, and you live in that same family. And let's say it happens to be the one that's making salad that night. And so they're making salad, and they didn't wash their hands. Okay, we can't figure out any nice way of saying this, but they didn't wash their hands, and so some of the eggs, okay, got in the salad. And you're sitting down at a table, and you ate that salad with the eggs in it. Okay, so what's the egg going to form in you? Larvae. Guess what they're called? Cysticerci. The larvae are actually called cysticerci. Are they going to form adults? No, it stops there. So what do you have? Cysticercosis. What are those larvae going to do? Oh, they'll penetrate your bowel. Where are they going to go? Oh, they love to go to the eye and the brain. Okay? And so they can migrate across your eyes. They can go anywhere they want, actually. But they love going to the brain. They form this nice big cyst in there that gets calcified, and you have seizure activity for the rest of your life. So isn't it interesting that in this particular disease, you can have two forms of it, where the adult could be a definitive host if they ate the infected pig. But if they get the egg in their mouth, then that could become the larval form. Then you have cysticercosis. Now you're an intermediate host, and you run the risk of getting cysticercosis of the brain and other things. Comprende? Good. I hope you got that down good now. All right? The rest of this stuff, forget. You don't need to know it. You've seen this before? You want to know why they call it a nutmeg liver? Because this is a nutmeg. Okay, and it's been cut in half, and so some idiots think that that looks like that. To me it doesn't, but some people do. These look to me not like dots, these look like lines. Okay, so, I think that's not really good. This looks like dots, that looks like lines. That don't look like that nutmeg liver to me, but whatever, somebody did. Maybe they have cataracts, and they have a distorted view of this thing. Who knows? Maybe it's on corticosteroids and they've had cataracts. Okay, all right. By the way, that's the most common complication of corticosteroid therapy, is cataracts, in terms of eye changes, not glaucoma. Cataracts. All right, what did we say the most common cause of this was? Please. Right heart failure. Very good. Okay. Let's put a thrombus in different places. Are you ready? Just like boys will. Let's put a thrombus in the portal vein. Would you have this liver, yes or no? Absolutely not, because it's before the portal vein emptied into the liver. But would you have ascites? Oh, yeah. Could you have the potential for portal hypertension? Oh, yeah. Varices? Oh, yeah. But is your liver big and congested? Oh, no. Now let's put a thrombus in the hepatic vein. Let's go Budd-Chiari syndrome. Most common cause, polycythemia rubra vera. Number 2, birth control pills. Would you have a liver that looks like this and probably worse? Absolutely, because the hepatic vein empties the liver. You get this huge, huge liver. And it looks a lot worse than this. There's a lot of hemorrhage and crap like this. It's an absolute surgical emergency. You die 100% of the time if you don't have surgery. So they like this because they really are interested in you and making sure that you know the normal blood flow from the portal vein to the liver and then being drained by the hepatic vein. So they put thrombi in different places and ask you what the liver looks like, whether, whatever. You understand? Very, very important. Pre-hepatic, post-hepatic thrombosis. Pre-hepatic portal vein, post-hepatic hepatic vein. Understand? Very, very straightforward, very simple, nothing really hard, but, you got to think about these things. All right, have you seen this before? Yes. Okay. Now, we're talking about alcoholic liver disease. We're going to go up to, but not including cirrhosis at this point. The most common manifestation of alcoholism is fatty change. Okay, fatty change. And we went through that already. We went through the mechanism of it. We said because of the alcohol metabolism, you got lots of NADHs, you got acetate, you got acetyl-CoA, you got lots of different things. You got the NADHs to screw around with pyruvate and convert it into lactate. So you get some fasting hypoglycemia and metabolic acidosis. You've got acetyl-CoA from which you can make fatty acids, and so you got something to add to glycerol-3 phosphate to make triglyceride and fatty change. You also can take acetyl-CoA, and the liver can convert it into ketone bodies, and you go from acetoacetic acid to beta-hydroxybutyric acid because that's an NADH reaction, so you have another reason for increased anion gap metabolic acidosis. So all those things we already went over, okay? It's totally reversible. Fatty change is totally reversible in an alcoholic if they stop drinking. They stop drinking. Okay, now alcoholic hepatitis is really bad, guys. You can die with alcoholic hepatitis. You can actually have hepatic encephalopathy, ascites, the whole bit. Now, an alcoholic hepatitis is different than fatty change in that there's fever, okay, you have neutrophilic leukocytosis, you have a very, very high enzymes. AST is higher than ALT. Gamma-glutamyl transferase is up. You are big-time sick. And if you don't stop drinking, you'll die. And, of course, a lot of people, when they might recover from alcoholic hepatitis, while they're in the hospital and they go out and drink again, and next thing you know, they're dead. This is a very serious disease because it's systemic. And you will die if you continue drinking. You have to stop drinking if you've had a bout of alcoholic hepatitis. And that's where you see your Mallory bodies. There's a Mallory body there. Remember, they've been ubiquinated keratin microfilaments. Now, they finally figured out what the toxic compound is in alcohol that does cirrhosis and does the damage to the liver, and it's acetaldehyde. They always thought it was, but actually it's not just acetaldehyde by itself. It's acetaldehyde bound to a protein. And that actually damages the liver. There's a cell, an interesting cell in the liver called the Ito cell. Not of Judge Ito fame, but it's spelled the same way. Now, the Ito cell normally is the cell that stores retinoic acid, vitamin A. That's the normal cell in the liver that stores vitamin A. As you remember, vitamin A is stored big time in the liver. When you're an alcoholic, the acetaldehyde protein complex stimulates the Ito cell and says, you will start making fibrous tissue. You start making collagen now. So here's a cell, the Ito cell, that used to be making and storing vitamin A is now being responsible for putting down collagen tissue and is responsible for the cirrhosis that one sees in the liver. Isn't that interesting? Well, makes sense because Judge Ito, you could tell him anything and he would do whatever you want. So that makes sense that it would change from making vitamin A into fibrous tissue. Makes sense to me. So fibrous tissue is a big part of alcoholic liver disease, and this is a trichrome stain here, and all of this is collagen over here, and that's our friend little Judge Ito there making collagen tissue instead of storing vitamin A. Okay, and we'll leave it at there at this point. We'll do cirrhosis a little bit down the pike. Okay, I love showing this, the big picture of this thing to the second-year students because they get totally entranced with this and they completely forget that that's a stone in the common bile duct. Because they're wondering about what is that white thing in the middle? What is that white thing? That's a sponge. Okay, and the sponge is actually underneath the common bile duct so that it can emphasize that this is the common bile duct with a stone in it. A second-year medical student will look at this and completely not see anything else. They won't see the green liver. The green, no, nothing. It's that. That's the pathology. No, that's a sponge. That's a sponge, okay? That's a sponge. You have to be taught, actually, how to look at things. Pathologists have been so used to, from looking at growths, we're very good at recognition. All pathology is, actually, is pattern recognition. So if you're kind of good at looking at pictures and remembering what pictures, go into pathology because you'd be excellent. Because it's all patterns. Kind of it's just like this. If you've seen one, you've seen them all. So if you've seen one really good example of this rare disease, and if you really have that up in your head, and another one comes along 10,000 slides later, you say, oh, I've seen this before. That's what it is. That's all it is. That's all it is. That's what pathology, pattern recognition. So we're very good at picking up changes in color and this and that, and so we're used to it. And so when I see students looking at that, I'm wondering, don't they know that that's a sponge? The answer is no. They really don't, because they don't have that experience to do that. Okay, so don't feel too bad if that's what you were looking at. Okay. So what we're talking about here is cholestasis. We're talking about obstruction to bile flow. Okay, and we have ourselves a cholesterol stone here in the common bile duct, and you can see that that liver is green. In fact, this liver is this one down here cut in cross-section, and I think you would agree that that's a deep green color. Okay, and that's because by doing this, you block bile, okay, which has conjugated bilirubin in it, and it's backed up into the liver. Okay, and now you have conjugated bilirubin will eventually reflux into the sinusoids, and so you have a yellow canary there with lots of bilirubin in your urine because of the fact that it's water-soluble. You also have what color stools? Light-colored. And do you have any urable lineagen? Any in your urine? No. But the urine's bright yellow, isn't it? But not due to the urobilin. What's it due to? The conjugated bilirubin. Very good. And what enzymes are elevated in this patient? Alkaline phosphatase and gamma-glutamyl transferase. Would it surprise you that they would have hypercholesterolemia too? Does that surprise you? What did we say was the mechanism for getting rid of cholesterol, please? Bile. So don't you think your reflux cholesterol, you don't think it's just going to be conjugated bilirubin, do you? You're going to reflux that too. You're going to reflux bile salts too. And they're going to deposit in your skin. And so what else are you going to have? Itching. Itching. Big time. Big time. Big time. Getting it? All right. Now, let's deal with two other causes of cholestasis. Okay, this one is a bile duct radical, and it's completely surrounded by fibrous tissue. And this patient has bloody diarrhea with left lower quadrant crampy pain, and now has some jaundice. What do you think the inflammatory bowel disease is? Ulcerative colitis. And then we have this common bile duct here that's surrounded by fibrous tissue, and it's obstructing it, producing jaundice. This is called primary sclerosing cholangitis. That's correct. And ulcerative colitis is the most common cause of that. And it will go on into what cancer, since it involves a bile duct? Cholangiocarcinoma. That's the most common cause in this country. What is it in third world countries? Clonorchis sinensis, the Chinese liver flu. Very good. Whoever you had in microbiology is pretty good. Who was it? Who'd you have? Who's good? Because you guys are doing really good on answering these things. You can always tell if someone's good when you answer questions, when you ask questions and they're coming back. You've been doing good on this thing. Wait till you get Hansen next week. Okay, then all those things that you didn't know in biochemistry will just be like, oh, I didn't. So you're ready to go after she's through with you. Okay, she's good. Now, here's a 50-year-old woman. Okay, and she's complaining of generalized itching. Okay, and so you examine her and you find out that her liver's a little big, and she's a little worried about it. You get some blood studies. Bilirubin's normal. Okay, alpha and gamma-glutamyl transferase are literally off the map. Transaminase is just a tad elevated. Okay, so we got a woman who's got generalized itching, got a big liver. She's got liver enzymes that are obstructive type enzymes. She's not jaundiced. What do you think she's got? Primary biliary cirrhosis. Now, just like you're wondering, why isn't she jaundiced? If, in this disease, it's an autoimmune disease with destruction of the bile ducts in a portal triads. That's what it is. It's a granulomatous destruction of bile ducts in a portal triads. And you're wondering, why don't they have jaundice right off the bat? Well, I had to think about that myself, actually. And I finally came up, not I, but whoever helped me, kind of came up with the idea of this. Let's say you have 1 million triads, okay? And let's say you have this disease, and you knocked off 250,000 of the triads by autoimmune destruction. You still have 75% of them that can still handle the bilirubin load, so there shouldn't be any jaundice. You with me? Now let's say 3 years later you only have 500,000, okay? But you still have another 500,000 that can just about handle the bilirubin load, so you still don't have jaundice. Okay, then maybe a couple of years later, you only have 250,000 left. Now, that's just too much work for those remaining ones, so now you're not able to handle the bilirubin. Now you have jaundice. So the reason why you don't have jaundice early on is you have such a reserve of triads that haven't been affected by the autoimmune destruction, and so there's no reason for you to have jaundice early. It comes late. It comes late. It comes late. And what's the antibody that you're going to order in this patient? Antimitochondrial antibody. Know what you could screw that up with? Antimicrosomal. You don't want to screw it up. So here's the thing. Here's the thing. You got two things that you could potentially screw up. Antimitochondrial, biliary cirrhosis, antimicrosomal, Hashimoto's thyroiditis. So you can screw this up. So what did I say is the best way of doing this? Remember one, the other one's the other one. Okay? And for me, I just remember the antimitochondrial for biliary cirrhosis. I just have it down, so I know that my antimicrosomal ain't it. It's the other one. The other one is Hashimoto's. Now, if you like microsomal for Hashimoto's, fine. But don't try to remember them both, because you confuse them again and you get it wrong. Remember one, the other one's the other one. Okay. Drug effects. Okay. I know Trevor taught you a lot about, side effects of different drugs, some producing a hepatitis type picture. We've got a lot of interesting ones for that, Aldamet, halothane, our little friend acetaminophen. I want to concentrate, however, on our little friend, the birth control pill. And I also want to throw in anabolic steroids. Because in the liver, a birth control pill and anabolic steroids have the exact same effect. So that's what we're going to talk about, because that's what the board talks about. Now, first of all, the birth control pill and anabolic steroids both produce intrahepatic cholestasis. In other words, let's say I'm a weightlifter. If I'm a weightlifter and they say I'm a weightlifter in the boards, what am I already on? I'm on anabolic steroids. And I develop jaundice. Okay. And so you could say, okay, the patient could have hepatitis, okay, but then give you more information. They'll say that the viral serology is real negative, and they'll give you the laboratory stuff, maybe, maybe not, and they'll say that, you'll look down there and you'll see transaminases just a little bit up, and you see very high alk-phos gamma-glutamyl transferase. And they'll say, well, what's the cause of this? And the answer is anabolic steroids, or they might just say drug effect, okay, it's not hepatitis. And the same thing can happen with birth control pills. The same exact thing. As a matter of fact, you all know, some of you women know, that one of the most common causes of jaundice in pregnancy is benign intrahepatic cholestasis. And that's because of the estrogen during the pregnancy causes intrahepatic cholestasis. And all you got to do is, after you deliver your baby, it goes away. Matter of fact, I'll tell you this. If you develop jaundice while you were on a birth control pill, okay, and then it went away when you went off the birth control pill, you're guaranteed when you're pregnant that you will develop jaundice because of the estrogen effect. Guaranteed. So that's a normal complication of anabolic steroids and birth control pills. Intrahepatic cholestasis. Now, you better listen to this one, because this one was very interesting. Both of these drugs also predispose to a benign liver tumor called liver cell adenoma. Another name, hepatic adenoma. Now, it's benign, but it has a nasty habit, and guess what that is? It likes to rupture. Ooh. You mean like rupture? Yeah. That would produce intraperitoneal hemorrhage. Right. That could kill you. You got that right again. Okay, look how right you are. But you're the one that's answering yourself. Oh, I am? I didn't know that. I thought it was the person talking. Okay. So, would you like the board question? You have a weightlifter. What does that mean? I'm on anabolic steroids. Who's weightlifting and suddenly becomes hypotensive and collapses. They bring him into the emergency room, and they find his belly's distended, and they do a peritoneal tap, and there's blood in there. Okay, they explore the patient and they find out that the spleen's okay, this is okay, and then they stop there. And they say, what's the most likely cause? The answer is they ruptured a liver cell adenoma that was put there because the patient was on anabolic steroids. That's how they did it. That, to me, was one of the trickiest of all questions I've ever heard on the boards. And I just didn't get it because they basically ruled out all these other things. And I was just thinking, I said, okay, I know that when they say weightlifter, they think anabolic steroids, and it dawned on me, the liver cell adenoma relationship. Okay? That's really pushing it on that question. But you know what? Now you know it. Okay, so you know that birth control pills and anabolic steroids have two similar effects. Both can produce benign intrahepatic cholestasis, yes. Just go off the drugs, it goes away. And they both can produce what tumor? Liver cell adenomas, which have a tendency of rupturing. You know, I'll give you some bad news, women. Bad news. If you're on birth control pill, right, for a while, then you went off them to get pregnant. Let's say you had a liver cell adenoma that you didn't know about, that you developed in the birth control pill. You get pregnant, and you get an intraperitoneal hemorrhage. Well, what would have to be in your differential diagnosis along with ruptured ectopic pregnancy? Ruptured liver cell adenoma. You bet, you bet, you bet, you bet, you bet. Here's another one. This is part 2. Ruptured splenic artery aneurysm. For some crazy reason, women that are pregnant get splenic artery aneurysms and they can rupture. That's part 2. Don't worry about it. I can see I already heard this the clicking sound. Okay. The clicking sound. You know what the clicking sound is, right? Yeah. Anxiety, anal sphincter. All right. Now this guy's not modest. Okay. Okay. He's just trying to show you that he's hyperpigmented. Okay, now. And it is a man. Okay, guys. In the stem of the question, if you come up with this kind of thing, that there's an adult who's diffusely hyperpigmented and who has diabetes. Okay? I want you to remember this forever. You ever heard of the term bronze diabetes? What are they always referring to? Hemochromatosis. That's how they do it for hemochromatosis. They'll describe a diffusely hyperpigmented person, and they'll say he's a type 1 diabetic. And they'll leave out all the liver stuff, they'll leave out the malabsorption stuff. That's it. They just hone in on the bronze diabetes. Bronze referring to you have a bronze look, and diabetes. That's iron overload disease. That's hemochromatosis. But let's go a little bit beyond skin and pancreas. Remember, hemosiderosis is acquired iron overload. Well, how do you acquire it? By being an alcoholic, that's one, because lots of iron in alcohol. Take Geritol, for example. Okay? By the way, that's an interesting question. Geritol's got lots of alcohol in it, and it's supposed to be for older people to get their iron, right? Do older people need iron? No. Matter of fact, it's iron overloading. You don't honestly think that a woman that's old requires iron anymore, do you? Why would a woman require iron when she's younger? Because of menses. You don't have menses when you're old. As a matter of fact, if you take excess iron when you're an elderly patient, you will create hemosiderosis and could end up with some of this stuff. It is actually contraindicated to take iron supplements in an older person. Great board question. You don't need it anymore, women. You don't have menses anymore. You don't need it. You're just iron overloading yourself. But anyway, getting back to this, you got hemosiderosis and you got hemochromatosis. Now that's a genetic disease, autosomal recessive. And what happens is instead of reabsorbing only 10 to 15% of iron from the food you eat each day, you reabsorb 100% of it. Okay, now the target organ for hemochromatosis is the liver. Okay, and remember we said that whenever iron goes into cells, it produces hydroxyl free radicals. So itself doesn't damage anything. It's the free radicals it produces, and they're hydroxyl free radicals. In fact, it's called the Fenton reaction, which you don't need to know. And so what happens is, if you're damaging liver cells, you're going to end up with fibrosis, and you're going to end up with cirrhosis. They all have cirrhosis in iron overload disease, be it from hemosiderosis or hemochromatosis. This is a liver, guys. This is a liver over here. It's got this brownish pigment, and you think you get the idea that there's a little bit of kind of like nodularity here. You get this little feeling over here. You certainly can here with this little portion here. This is an iron stain. This is a Prussian blue stain of this. And look at all that iron in there. Look at all that fibrous tissue in there. So it produces cirrhosis and all the changes that occur with cirrhosis, including a very, 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 very high incidence of hepatocellular carcinoma. In fact, one of the highest of all the incidences of hepatocellular carcinoma is iron overload in the liver, big time, 30% plus. Okay, but it can go elsewhere. It can go in the pancreas too. I say here's the pancreas from a patient with hemochromatosis, and this is it unstained, and this is stained with Prussian blue, and you can see the whole sucker has got iron in it. So you're going to have the exocrine and endocrine problems. You're going to destroy your exocrine cells, so you're going to have malabsorption. And you can destroy your islet cells, and you are going to have type 1 diabetes, and I might add it's very brittle type 1 diabetes. And it also can deposit in your skin and give you that bronze look. It should actually be that iron look, actually, because it's not bronze. Okay? It's a combination of iron deposited there and iron-stimulating melanocytes. So it's a combination of increased melanin, pigmentation, and iron. Okay? It can go into your joints and produce osteoarthritis. It can go into your pituitary, produce hypopituitarism. It can go anywhere it wants. Go into your heart and produce restrictive cardiomyopathy. How would you screen for it if you suspected you had a patient with iron overload, please? Serum ferritin. Okay. But could you give me the rest of the studies? What would the serum iron be, please? High. Now, I want you to think before you answer the next one. Next one is, if you have excess iron stores, what happens to transferrin synthesis? Decrease. So what's the TIBC in iron overload? Decrease. Very good. Percent saturation. Increase, and serum ferritin increase. You got it. Treatment. Treatment is phlebotomy. They don't use chelation therapy. No. They purposely make you iron deficient. That's the treatment. Phlebotomy. Always ask, guys, you want to know what? This, next to von Willebrand's disease, is the next most common autosomal recessive disease. Autosomal dominant. No, wait a minute. This is autosomal recessive, this one. Von Willebrand's is autosomal dominant. But it is one of the most common autosomal recessive diseases. Big time. I think it's less than 1 in 100. Big time. Big time. Okay. All right. Why would I do this? I show a stinking eyeball in the brain. I thought we're on the liver here. I thought we're on the liver here. What's this nice little... That's a Kaiser-Fleischer ring. What does this patient have? Wilson's disease. And what's this degeneration over here called? Hepatolenticular degeneration. So this patient would have an abnormal movement disorder, dementia, and cirrhosis. Okay, so how does this disease work? It's autosomal recessive, and it's a defect in getting rid of copper in bile. Can't get rid of it. So the copper builds up and accumulates in the liver. Very toxic. So over a period of months to years, you go from a chronic active hepatitis to cirrhosis. All right, let's stop there. When you get a total copper level, what do you think it includes? Well, it includes free copper and the binding protein for copper. That's binding copper. What's the binding protein called, please? Ceruloplasmin. Okay. And so some copper is going to be attached to ceruloplasmin. So it's bound and free. That's measured with a total copper. Now listen to this point, otherwise you'll blow this question right out the window. 95% of a normal total copper level is related to the copper attached to ceruloplasmin. So in other words, most of the total copper level is the copper bound to ceruloplasmin, not the copper that's free. Only 5%. Guys, you don't want to have a high free copper level. Otherwise, you're going to end up with that. Okay? So 95% of in a normal person of a total copper level is the copper that's bound and inactive to ceruloplasmin. Are you following me? I hope so. So is ceruloplasmin a protein? Yes or no? Okay, so if you have cirrhosis now, Do you think you're synthesizing ceruloplasmin anymore? Yes or no? So that decreases, doesn't it? So that means you don't have a whole lot of binding protein for free copper anymore, do you? And so the free copper level starts increasing because your binding protein is decreased. But listen carefully. So therefore, what's the total copper level in patients with Wilson's disease? Decreased. Why? Because ceruloplasmin is decreased. But what's the free copper level? Increased. There you go. You know what your natural tendency is to say? Your natural tendency is to say that in Wilson's disease, the total copper level is increased. No, it isn't. It's decreased. And the reason why it's decreased is because ceruloplasmin synthesis is nil. So, and remember, that accounted for 95% of the normal. So it's actually decreased. It's the free copper level that's increased. And that's when you start getting a Kaiser-Fleischer ring like this, okay, and when you start getting the lenticular nucleus degeneration. So please, please, please do not put increase in total copper level in Wilson's disease. If you do, you're going to get it wrong. Okay? So how would they put it? What would be other choices? Well, they could say decrease total copper, but they usually don't do that. They could say as an answer, increase free copper levels. That would be correct. Or they could say if they want to decrease ceruloplasmin levels, that would be correct. But if they said increase total copper levels, that would be incorrect. How would you treat this? Penicillamine. Penicillamine's a copper binder. Okay? They like this. Why? Neuroanatomy. Wait till we do CNS. Wait till I show you a brain cut in cross-section without a tail of the caudate. What are you going to tell me if there's no tail of the caudate? In other words, it atrophied and they have an abnormal movement disorder. What are you going to tell me? Hepatobiliary-Pancreas. That's how they're doing neuroanatomy now. They're giving cross-sections, and they're putting the normal anatomy there, and they're labeling all the different parts of it. And they'll say which of the following things would be abnormal in a patient with. And then they describe some clinical scenario. Let's say it sounds like Huntington's, and you have to pick out which letter would represent the caudate nucleus would be abnormal. Do you understand? Well, they can do that for Wilson's disease, too. They can give all this history about this due with the abnormal movement and a family history of liver disease and some eye abnormalities. So you know it's Wilson's, okay? Then you don't know where the lenticular nucleus is. And you're screwed, okay? You're screwed, big time. Are you following me? I'm showing you how they do it. Once you know how they do it, then you have half a chance, more than half a chance of getting it right, because you're kind of familiar with what they do. Okay, now we're talking about cirrhosis. Very good. Thank you for that chiming in there. That's very, very good. All right. And some of you thought this was a normal liver, and you thought that's not good. That's not. It shouldn't have bumps all over the place. Now, cirrhosis is never focal. Cirrhosis is always diffuse. Okay. We call these little bumps regenerative nodules. Regenerative nodules. Okay. Now, you know that liver tissue is stable, which means that it's usually in the GO phase, and then something has to stimulate it to go into the cell cycle and divide. Okay. Isn't it true that the liver has an amazing regenerative capacity? In fact, a surgeon can remove a whole lobe of the liver, and over time, that'll grow back. But I'm going to ask you a question. Is it normal liver? How could it be? Does a carpenter build a house without a foundation? Is he nailing wood into nothing? Or is there a foundation there that he has to nail it against for it to stick up? What do you think? Okay. You don't honestly think that you're regenerating the basement membrane, you're regenerating the blood vessels, and all that. All you're regenerating is the liver cells. So no, it is not normal liver. It's just one big pile of hepatocytes with no sinusoids in between, no triads, no central vein, no nothing. It's just wall-to-wall hepatocytes that are absolutely worthless. Similarly, that's what regenerative nodules are in cirrhosis. They've been injured, and they're regenerating, but they can't regenerate a basement membrane, they can't regenerate a portal triad, they can't regenerate a central vein, they can't regenerate a sinusoid. They're absolutely, totally, unequivocally worthless. Let's stop on that. That was, sounded like I was talking about a person there, wasn't I? I was talking about, though, the liver cells, okay.